we're going to focus this coalition meeting on the Not 62 campaign that Bronx Health REACH co-founded along with our president's office, Montefiore Health System, the New York City Department of Health, at the time called the Bronx District Public Health Office. They will forgive me, Anita and others, if I cannot remember their changing names. But we came together, just as a bit of background and introduction, we came together because New York City Department of Health had received a small grant to do a video, to produce a video addressing the fact that the Bronx was 62 from the very inception of this County Health Rankings report that the Robert Wood Johnson Foundation had sponsored, and the University of Wisconsin had the responsibility of doing the research, collecting the data, then doing the rankings and producing it. The Bronx has unfortunately been ranked 62 out of New York State's 62 counties. And when the Bronx Health Office pulled a number of partners and collaborators together to do this video to, speak forthrightly about the fact that we're 62, about the challenges that we have, the determinants behind that 62, we decided that we wanted to do more than just produce a video, that we wanted to come together and pull so many of the partners that are doing work in the Bronx to mount a campaign for a healthy Bronx. I think one of the very early successes of that was that we actually applied for and was a prize winner. The Robert Wood Johnson Foundation has a community health prize for communities that are trying to make a difference in addressing their health outcomes. And I remember at the time when it was a multi-tiered application system, if I'm correct, it was at a 3 or 4 different levels. And when we got to the point of having a site visit, we asked, well, what chance does the Bronx have in winning this prize and being one of these community health awardees, given the fact that we were at the bottom. We were last place in terms of the rankings in New York State. And we were heartened when the response was, we're from RWJF folks, the people doing the site visit, that they were not so much focused on where a community ranked, but what was the community doing? How has the community been pulling together partners and collaborators to address its health, its the factors that were playing up in its county health rankings? And they were absolutely right, because even though the Bronx was ranked 62, we were one of, I think, at the time we got an award, one of 8 from across the country of all the counties that had applied. And so that gave us even more energy and commitment to working on this. The steering committee has continued to focus. We actually, earlier this year, added new members to the steering committee. So there is interest in other people wanting to be part of this, for which we are particularly proud and happy. So with that being said, I'm going to invite Dr. Johnson to speak, maybe introduce herself a little bit, and then to take it away. Dr. Johnson, again, welcome, and we're so glad to have you.
Thank you so much for the invitation back and the chance to be in dialogue with all of you. And that summary was a really helpful segue into the content that we will share today. So I am actually in Milwaukee. I work at UW-Madison, but I am born and raised in Milwaukee, Wisconsin. And Milwaukee also has the lowest rank in our state. So we have 72 counties in Wisconsin, and Milwaukee is usually 72 or 71. We switch places with Menominee County, which is a Native American county in Wisconsin. So this is a issue that I'm personally familiar with in terms of being a person who lives, works, plays in a community that, according to the rankings, ranks low, while simultaneously knowing in my heart and in my daily life that there's so much happening within our community to improve health and to work together across sectors. So I am joined today by two colleagues, Kate Barnes and Eunice Park, and they are going to be helping out in the chat with specific data questions or putting links to the county snapshot and updates that we've provided. And if you all feel so inclined, you can go to countyhealthrankings.org and pull up the Bronx snapshot. And I'll show you a little bit about how to do that as we go through. So I'm going to share screen. Oh, yep. Okay. And get started as soon as I find the button. Okay, so going to talk about moving data to action. And as you said, County Health Rankings and Roadmaps is a program of the University of Wisconsin Population Health Institute. It's the result of contributions of many people across more than 15 years of work in Wisconsin and across the nation, and it has funding support from the Robert Wood Johnson Foundation. And so hopefully today we will walk away with increased understanding of the County Health Rankings and Roadmaps County Snapshot for the Bronx and how you can continue to use it for health improvement, and also increased understanding of how to find strategies that have been reviewed and analyzed to address your own community priorities. So at County Health Rankings, we are hopefully in the business of helping to grow community power to improve health equity. And so all of the resources that we develop and disseminate are done with the intent of supporting communities, local communities, to improve health equity. So we think about health equity in a lot of ways. We tend to, for a very short purposes, use Paula Braverman's definition, and her short version of it is that health equity means that everyone has a fair and just opportunity to be as healthy as possible. But there's a longer version of that definition from about 2017. And it goes on to say that in order to achieve health equity, it requires that we remove obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and a lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. And so in that list, you probably recognize what's often termed social determinants of health, and even a hint toward what Kamara Jones and others have called social determinants of equity. So when we think about powerlessness and who has say-so and who has the opportunity to use their voice to demand things from our collective polity, that's really getting at the social determinants of equity. The Robert Wood Johnson Foundation recently did about a 2-year study on how to talk about structural racism as one of the primary drivers of health inequities in the US. And they did extensive message research and developed this new image to help us all talk about the ways in which structural racism currently impacts health in our communities and has historically impacted health. And so what they do is show the ways in which some communities have been built with barriers, such as exposures to toxic dumps, businesses that are not effectively zoned and make it easier to find liquor than healthier foods, public officials who have yet to resource safe drinking water, safe housing from a known toxin like lead. And on the other bridge, where you see no obstacles and actually investments in health around public budgets that fund schools and healthcare, that it's easier to be healthy in communities where they've been built from the get-go to create health. And what this research does is try to demonstrate that these policies were intentionally developed by people. And because they were intentionally developed, we can also intentionally work together to build new bridges. We can rewrite new laws, we can enforce existing laws so that we are building a society where everyone has the opportunity to thrive and all places can thrive. And then things obviously get better for all of us. So they haven't, excuse me, publicly disseminated this resource yet, but they've invited us to share it. And I think it will become a public resource for communities across the country soon. In my last time with this group, though, I used a different visual image. And I used this image here of a 1970s, I believe it's a Fleetwood Cadillac, but it might be a different model of Cadillac. And I have Malcolm X driving it. And I think those might be New York license plates, I'm not sure. And often when I do this presentation, people quickly ask, well, what does Malcolm X and Cadillac have to do with public health? And this is a quote that Malcolm X has been quoted as saying by Professor George Lipset, that racism is like a Cadillac, that even though a Cadillac from 1950 or 1960 looks different than a Cadillac that came off the production lines in 2020, it's still a Cadillac. And it's the same with racism. Even though the racism of the 50s or the 60s, where we in the South had active Jim Crow laws, in the North we had restrictive covenants and redlining, and job discrimination, regardless of the way that racism looks in a particular historical context, it's still racism. So just like Cadillac comes out with a new model every year, racism also comes out with a new model every year. It adapts, it shape shifts, it adjusts to continue to do the work it's designed to do, which is to devalue certain groups of people based on a socially assigned category of race, and to overvalue other groups of people, including the ways in which that valuing results in the construction of community conditions that either lead to health or detract from health. So whatever imagery you use, it's important, I think, to wrap our heads around the idea that the Bronx and other communities like Milwaukee that have been have experienced place-based structural racism and other forms of divestment are at the bottom of our rankings, not because of the individual failings of people in those communities, but because of a set of intentional policies and practices that once we are aware of them and interrogate them, we can undo them and replace them with policies that both repair the harm and promote health for the future. So an example of this again in Milwaukee, on the right, you see the construction of a freeway that bisected the predominantly African-American community in Milwaukee that had migrated to Milwaukee as part of the Great Migration. The collective behavior of people of African descent, many people who descended from formerly enslaved people, to seek better life, and established what you see here on the left, a vibrant community of businesses and churches and cultural arts and home ownership and strong family systems. And yet there were decisions made by our government, and the government is, of course, elected by the people, that resulted in the destruction of this thriving part of our city for the purposes of construction of a freeway. Now, this is not unique to Milwaukee. It's something that's been documented across the country, that communities of color, particularly communities that were largely African-American in the South and the North and the West and the East, experience this same targeting because of the overarching notion of undervaluing Black lives. And so what this does is it turns a community literally upside down. It creates root shock, as Professor Fullilove in New York has described, where people are, oh, yeah. Oh, I thought somebody was asking a question. It removes social and economic resources. And we know all of those things are related to how long and how well people live, both individually and as a community. So what about the Bronx? You all know this better than I do, that similar things have happened in the Bronx, both the construction of what I think you all call the Cross Bronx Expressway, the experience of redlining in the Bronx that resulted in massive differences in the ability to have safe, affordable homes, massive differences in exposure to toxins, and therefore massive differences in how well and how long people live in particular communities. And so the good news, I think, in the Bronx is that when you look at your county snapshot, there are some areas where things are improving, and air pollution is one of the areas where you can see the top red circles are showing a trend toward healthier air in the Bronx. The study that I showed you on the previous slide notes that there is still an extremely, and you all know this better than I do, high rate of asthma, some perhaps some of the highest rates in the country in the Bronx. And the community activism and grassroots organizing and working with elected officials that I think is represented in this previous slide has resulted in changes in the physical environment that are likely to have long-standing positive improvements on the health of the people in the Bronx. And I'm certain that many of you were involved in getting this done. And so this is what I think y'all were talking about at the beginning about, while the rank itself may not have changed, there are significant actions on the ground happening to improve the underlying measures that go into the rank of the Bronx. So how do we know then if we're making progress toward this idea of health equity? How do you all know what's the best way to keep track of this? And so one of the things that I think we'll talk more about is whether the rank is the thing to be using to track progress, or whether the underlying data that are represented in the broader model are really where communities should be focused. So this is the model that County Health Rankings and Roadmaps currently uses, and it serves a number of functions. It serves the function of helping a broad swath of the population, both people that are working directly in public health or healthcare, and people who might be working in adjacent sectors like education or economic development, and even the general public, helping them to understand that health is more than health care. And if you look at public opinion polls conducted by, a number of reputable research and practice institutions, there's still a pretty widespread belief that healthcare is the primary driver of how healthy people are individually and at the population level, despite hundreds of years of science and wisdom from lived experience that suggest otherwise, that healthcare is a part of the puzzle, but it is not the primary driver in most places, in most contexts of how healthy a population is. And so what this model does in a very hopefully simple and easy to digest way is to show people that social and economic factors, and the physical environment are some of the underlying factors and conditions that particularly shape behaviors. So whether or not one can diet or exercise, for example, is largely contingent on the ways that the physical environment and the social and economic factors that you experience are shaped. And so that is the point of the model, to show that there are multiple factors that contribute to health and produce health, both health outcomes in terms of length of life and quality of life. And that underneath there in that orange box, that these factors that are driving health outcomes are driven by policies and programs. And these policies and programs don't come out of nowhere. They come out of our shared decision-making processes, our shared decisions about resource allocation. And those are things that we can impact. And in order to impact them, it's important to pay attention to the need to shift power, to shift who has a say-so in the policies and programs that we decide to implement or not. And so the model is evidence informed, absolutely. It is, rigorous in terms of the underlying science that demonstrates that social and economic factors in the physical environment are key drivers of health. But it really shouldn't be taken literally, in that these weights that we assign to the factors are set in stone and exactly 20% in every place, that the decisions that we made about how to measure length of life and quality of life are the end all and the be all. And so similarly, needing to understand what's under the hood in this model, and how do you use what's under the hood to continue the work that you're doing. And so what you can do is jump into your snapshot that is at both the county or state level. You can start over here on the left hand by just typing in the Bronx or your zip code or your state. Or you can search for data by topics related to those that are identified in the model. And you will pull up a county snapshot with just a gold mine of data and other resources that will show you a bit as we go along. So about the data, so what's underneath the hood other than the rank? There are county level measures for from more than 20 national and state data sources. They are the most recently available data, but that doesn't mean it's the data from the year that we released the rankings. So due to all of the necessities of good data science, some of them are not available the same year that we published the rankings, but we are very transparent about the data sources, the time frame for the data, and any changes that we've made in data sources that might impact how you use the data for local change. Most of the data, the vast majority that we use, is publicly available, and it's available at no charge, certainly to you and to us. So it's verifiable. If you wanted to go back and recalculate the things that you find in your county snapshot, you would be able to do that for those reasons. And the data are reliable and valid from a scientific perspective. So why do ranks change then? Why might the Bronx or any other place experience a change in rank? So the most obvious answer to that question is that your county might have experienced health gains or health losses. And I think that's where most people sort of come into this conversation. But there's some other reasons that are artifacts of the statistical and mathematical workings that also can impact why ranks do or don't change. So one other reason is that other counties experienced health gains or health losses. And so a county's rank may also improve or worsen due to changes in other counties in your state that ranked just above or below you. And then also there's random variation in measures. So all measures experience some variation year to year, and a change may be caused by some random variation in the measures that comprise the rank. So that doesn't mean that the data is not useful or they're not trustworthy or not dependable, but these are important understandings as you think about how to use both the rank and the underlying data for the work that you're doing. So why do we use ranks then? This is a really important question that we are interrogating ourselves in terms of how the cost benefit of using ranks. And the short version of the answer is that ranks get attention. They are excellent conversation starters. They are things that most people understand. We use them in basketball. We use them in every in many day-to-day aspects of our life. And so for a communication tool to both the media and the general public, it's a easy to use and effective conversation starter. Oops, sorry, pressed the wrong button. Okay. But ranks themselves aren't the whole story. No, I can't make it go. There we go. So they are relative, and that's what I meant when I showed you the first slide about they are dependent on relationships to how other counties in your state are doing. And they communicate order, but they don't really tell us anything about the size of the difference between ranks. So here you see number 1, number 2, and number 3. The distance between number 1 and number 2 is much bigger than the distance between number 2 and number 3. But in an ordinal ranking approach, that doesn't change the fact that they're listed as 1, 2, and 3. In addition, even if number 2 and number 3 have substantial progress, they are not necessarily going to experience a change in their rank. And so that is why we start with a rank as a conversation starter, as a call to action, as a way of gathering some momentum around community health improvement. But then we really recommend that local communities dive into their data snapshot to understand what's under the hood and where things are improving and where they may need to focus more attention. Want to give a moment to Kate or Eunice to share any other reflections on this idea here. And I can't see everybody because I'm not using 2 screens.
Thanks, Sherry. Nothing for me. I think you covered it really well.
Me neither.
Okay.
Thanks, Sherry.
Sure. And so what I just said, ranks don't always capture the progress that you're seeing internally in a county. So let's look then at some of the questions that you all asked us in advance about what is happening under the hood in the Bronx and how can you use this data to continue the work that you're doing. Sorry. Go backwards. Or trying to get rid of the people screen. There we go. Okay. So this slide really does look under the hood. It shows you the math that's under the rank for health outcomes. And some folks might be thinking, well, who decided that? Who decided that 50% of a health outcome ranking should be due to premature death, while only 20% is due to low birth weight or poor or fair health? So these are decisions that we made at the university based on good science, and we stand by them. And it's not perhaps the only way to measure health outcomes. But what you do see in this snapshot is significant, and I won't say statistically significant, but significant improvement in the premature death rate in the Bronx. And you look at the red circles at the top of the graph compared to the triangles that represent the whole state and the squares that represent the whole country. And you can see that while the Bronx premature death rate is still higher than the whole state or the country, early on in the late 1990s, there is a progression toward improvement and a progression toward closer proximity to premature death that's experienced statewide or nationally. And so these are signs of progress. The data don't tell you why there's an improvement in premature death. And so that's also part of the next step that I think your agenda suggests that you'll be working on. How do you work together to understand what's happening that is contributing to improvement and what else needs to be done? So you can dive even further into the snapshot and look at data that is disaggregated or broken up by socially defined racial or ethnic groups in your county, and also look at the leading causes of death or premature death under age 75 and what those causes of death are. These data are age adjusted so that they're more comparable across places that might have a different distribution of age of people in the county. So some counties might have more younger people, some counties might have more people that are older, and so the statistical methods adjust for that. But you can see that there are some leading causes of death where you may want to focus your efforts to improve length of life in the Bronx. One of the questions that we got in advance was, well, where are we seeing the biggest changes in data in the Bronx from 22 to 23? And so the biggest changes that we saw in data that we include in the ranking, the ranked data, meaning some of the measures in the model are used for the purposes of calculating the health outcomes rank and the health factors rank. And there are many other measures that we call additional measures that we know are important for understanding how health is produced, but we don't incorporate them into the overall ranking. So that's another way of understanding the difference between how you use a rank versus how you use what's under the hood on your county snapshot. But the good news is that there are significant improvements, again, not statistically in terms of a measure of statistical significance, but notable, I should say, improvements in self-reported poor or fair health and poor physical health days. Both of these are self-report measures that come from national data sources at the county level. But there's good evidence, and I know lots of other people on the call would be able to dive into this, that what we say about our own health on surveys is actually pretty highly correlated to actual measures of health that might come from an external source that's going to measure some aspect of your health for you, like blood pressure or something like that. So compared to other counties in the state, the Bronx is showing a really good improvement in this area. We also pulled out selected health factors, those are the things in the blue boxes that that comprise the overall health factor ranking and health outcomes. where there are some really positive signs. And so in the column where you see a sun, that's a place where there's either steady state of something that's positive or improvement. And so limited access to healthy food across both years, that has not been an issue as we measure it in the Bronx. Physical inactivity is improved. Inactivity, so the reason going down is good is that fewer people are reporting inactivity. Access to exercise opportunities is strong in the Bronx. And then the health outcome measures that are, like I showed you in the previous slide, underneath that, that hood of premature death and causes of death. So seeing an improvement in diabetes and HIV prevalence. You can go into your snapshot and pick out areas of strength just by clicking on the boxes that are in that snapshot area, and it will highlight areas of strength and areas to explore, which is a euphemism for areas that aren't going so well and that you should pay more attention to. And so the areas of strength can be compared to the state averages and to the United States. And you can see here that there are many areas of strength in the health factors area across clinical care. Social and economic factors are less are not represented in the areas of strength, but some of the clinical factors and outcomes like injury deaths, as well as the physical environment, driving alone to work, and behavioral factors like excessive drinking are areas of strength in the Bronx. When we look then at areas to explore or areas that you might want to pay attention to, these are listed here. So the Food Environment Index is a composite measure that looks at both the availability of fresh food and the affordability of it. And so what we've tried to do as we continuously analyze the measures that we use and improve them when there is available data is look at the context as broadly as possible. So if you have access to fresh food, but you can't afford it, then it's not particularly useful. So this Food Environment Index is one of those composite measures that attempts to bring in more of an integrated understanding of what's happening. You can look again at social and economic factors like high school completion or children living in poverty and income inequality. And these are areas that compared to the state as a whole or the United States, the Bronx has more barriers. So back to that slide that I showed you with the picture of the bridges or the definition of health equity, these are the obstacles and barriers to health equity that need to be removed in order for people to thrive. It isn't that people should simply sort of pick themselves up by their bootstraps, and I'll get to that later, but we need to remove the barriers and obstacles that have been unfairly constructed so that people can thrive. It doesn't also eliminate the idea of individual responsibility or agency, but it doesn't privilege the notion that people should, or it doesn't, I should say, overemphasize an idea that people should be solely responsible for their health, regardless of the conditions that have been created over centuries and generations. So I often say, you know, it's a both and. There are lots of ways that you can use the data underneath the hood and lots of ways to show data. So we provide trend graphs that you can see down there at the right. And that trend graph is measuring the percent of children who are living in poverty in the Bronx compared to the state overall and national. You can disaggregate many of the measures by socially defined racial groups, and you can map the health factors across the state. We have heard through external and internal evaluations that a large value of the data set and these multiple ways of demonstrating data that local communities have reported is that you can use it in things like community health improvement plans or one-pagers as you're advocating at the local or state legislative level, or community information sheets. And so that's why we produce it. So you can use it for grant applications, for tracking progress, not on the rankings necessarily, but on these underlying measures of health. This year, we added 2 new measures, and these are unranked additional measures. And this is part of our evolution toward continuously moving what some people call upstream, or what other people call into root causes of health and equity. And so we have added census participation and voter turnout as data, as measures that you can look at the county level. And we do this because we know that as regards to the census, resource allocation largely depends on what we learn from census. And so understanding how well we're doing with measuring the demographics of our communities through the census influences the distribution of power through government representation, allocation of resources, and public health planning. And then voter turnout, there's a lot of research that shows that communities that vote tend to be healthier, and healthier communities vote more. So there's this bi-directional chicken and egg thing. But we know that as people have increased opportunity to use their voice and their experience to shape policy and practice, that we often see major progress. And so in our national findings report, we cite both the enfranchisement of women in the 1920s and the ways in which enfranchisement of women resulted in significant increases in investment in everything from birth and vital records data collection to maternal child health programs. And so that role of say-so is really evident there. And then we also cite the ways in which enfranchisement of African-American people during the civil rights era resulted in significant changes in investments and significant improvements in health as barriers and obstacles were removed. And so Nancy Krieger has a couple of papers that you might be interested in that looked at Jim Crow polities and the differences in infant mortality when Jim Crow and the relationship to Jim Crow and hospital segregation was removed. So that is something to take a look at and to continue to think about how you use it for local health improvement. So I'm going to shift now, but I guess I can take a moment again and see if there's any questions now, or we can keep going and we'll get to questions at the end if anybody, I'm not monitoring the chat. So Eunice or Kate, anything in the chat that we should stop and address?
We've been answering questions in the chat, but if anyone has questions specific for Sherry, it sounds like she is open to hearing those right now.
Well, if y'all have been answering questions in the chat, I'm going to keep going and then we'll finish up because I'm watching time. Okay, so the second half of the, oh, go ahead.
Before you go, there's a question. Thanks to Kate and the others who've been answering the questions as they come up. But there's a question Maxine Golub just put in about, is the data available by zip code? So which would lend itself better to being able to plan for local interventions.
Yeah, that is, unfortunately, we don't have the data by zip code. And we hear that as a ask for more granular data almost every day. And we agree. We know that within counties, there are vast differences by zip code in access to resources and decision-making about resource allocation.
Okay, thank you.
There are some other data platforms like the Area Deprivation Index and that's the one that the Social Vulnerability Index by the CDC that I think have more granular data. But that is not something that we've been able to add to our site.
Jerry, what was that last one you said that's used by CDC?
Yeah, the Social Vulnerability Index is a CDC product, and I believe it's at the zip code level. Eunice or Kate might be able to correct me. And the Area Deprivation Index is something that is computed by Amy Kind's group. And if you all can put something in the chat there, some links, that would be great.
There is a link in the chat to the Area Deprivation Index.
Great. So, so the first half of this was sort of, why are we using ranks? What are they good for? What are the cautionary tales about what they can do and what they can't do? And the second part now is going to be the so what. So we see this rank, it hasn't changed. Now we may know that there's more under the hood that we could use to continue the work that we're trying to do. How do we know what to do and whether it's going to work? So the biggest hidden gem on County Health Rankings and Roadmaps site, in my view, is the What Works for Health toolkit. You can find it by going on the Take Action drop-down menu on our main homepage. And it is a library, a treasure trove of more than 400 plus strategies that our research analysts have analyzed and what we call curated, so that local communities can decide on which priorities they want to focus on, and then have an easily accessible way to look for policies and programs that might help improve the priority that they have selected. So the tagline of this team is, we read it for you. You can search, by any of the main factors that we include in the model. So health behaviors, clinical care, social and economic factors, and the physical environment. And I've just pulled up 4 strategies that are included that address the social and economic factors, and in particular can be helpful in addressing the childhood poverty measure that I showed you as one of the examples in this presentation. So you can go look at paid family leave and earned income tax credits and childcare subsidies and flexible work scheduling as strategies that you can advocate for and work to implement, either at, sometimes these are state level, sometimes these are county or city level. And so understanding where in the spectrum of policy making a particular strategy lies is important, but it also helps shift the narrative when local coalitions help residents understand that this is not a problem that individual people have created for themselves. This is a function of systems and structures that we have created. And since we have created them, we can change them. And so when you go into what works for health, you'll see a description of a particular policy or practice. You'll see an evidence rating, and we try to use relatively easy graphics so people can see that, a lot of green bars means it's good, go. It's scientifically supported, meaning it's had multiple rigorous scientific studies to support its effectiveness. We include implementation resources because we know that just because it's written in a scientific journal doesn't mean that anybody knows how to do it in real life, and that the difference between what's done in a scientific study and what's done in the real world requires a lot of science to implement. And so these are examples of where people are actually doing the thing. And then we have a disparity rating that we've updated as an equity analysis, where we know that some interventions might lift all boats, which is great, but they might not close the gap between groups who are experiencing different outcomes. And so this is a way to think even more carefully about which interventions, policies, or programs you select and implement depending on the goal of the work that you're embarking on. And so the equity analysis is includes a disparity rating, likelihood to decrease disparities, increase disparities, or have no effect at all. A rating description that describes how we came to that conclusion. Historical context, which is a new addition, and one that I covered in this presentation with the example of highway construction. So each of these strategies now has a paragraph that describes a historical context of how things got to be the way they are and why things don't have to be that way. So they attempt to briefly get at some of the root cause or upstream drivers of poor health. And in addition, I didn't say, but in your county snapshot, we've also added historical context under the demographic section. So you can now see that the Bronx is a place where the homeowner loan corporation, that was the entity responsible for implementing redlining, which has had generational impacts on health through multiple pathways, including the missed opportunities by design to create economic stability and wealth amongst certain groups of people. So that context is now lifted up in the county snapshot description, as well as context that you can link to around the native indigenous people whose land we continue to occupy. And then there are equity considerations, and these are questions that we pose to help local communities think through the questions about, rising all boats versus closing gaps, and how you think about those and how you think about them in the process of implementation. We have curated lists. So we added a racial wealth building list that includes an analysis of the potential health benefits of reparations and reparations for people that experience housing discrimination, as well as strategies related to home ownership. And then we have 3 other strategy curated lists as well that address priority topics that we've heard from people who use the site. And then the last part, and I'm just careful on time, and tell me if you want me to stop now or keep going.
How much more do you have?
I think there are probably 3 slides, and I can go super quick.
Yeah, let me ask you to go quick. So we give a few minutes. I know people have been posting questions in the chat, but I suspect that there are people who may have questions that they want to ask and talk about. So if you could finish off your thing quickly, that would be great.
Okay, great. So this is really just a caveat about how you communicate about data. The data don't speak for themselves, that it's the questions that we ask or don't ask that shape what we discover or don't discover. And so interrogating the underlying narrative of both how we collect data and how we report it is important. So we've been working on narrative as a tool to understand how we communicate data. This is an example of how research can create a narrative. This is David Williams and colleagues' work around the mental health impacts of being exposed to police killings of unarmed Black people, even if you weren't the direct target of that killing. And then you see in the conclusion that they conclude that the goal should be to decrease the frequency of police killings as the focus of resource allocation and mitigating the adverse mental health effects. That's the way that we shift narrative that can then result in shifting the way that we resource our systems and structures. I'll go quickly, and I think I can skip most of these. But we'll end here that stories are critical to contextualize data. They spark curiosity and empathy. And as you all are not 62, I know that you have a wraparound approach of stories that you use that ranking as a
Jackie's on the phone. Good morning. Good morning.
So I will end there and happy to take questions.
So we want to thank you for that presentation that gave us a good briefing on the rankings report. Are there any questions from folks? If not, have one or two myself. Neil, you have unmuted. Go ahead.
Yeah, just what are our odds of ever being not 62?
It's a great question. I mean, what I would say is the ways in which the Bronx experienced unfair policy and practice and resource allocation, especially in that era of housing discrimination and the burning of the Bronx, et cetera, and the flight of people with resources, that it's a long haul. It's a long haul for all the communities that have experienced that type of disinvestment and intentional harm. And I think that the strategy of social solidarity, in terms of both solidarity within the county across various identities, but also working to build alliances with the counties that have experienced unfair advantage, and trying to prick the consciousness of the counties that are just, perennially ranked 1, and getting them to understand that they're not ranked 1 because the people there are so great. They're ranked there 1 because of a set of policies and practices, and that the hoarding of resources is not good for any of us. It's going to come to bite us all in the butt. That's a very unscientific conclusion.
Yeah, I mean, the reason I asked the question is because I guess 2 reasons. One is, we're hoping that everybody gets better. We're hoping 61 gets better and 60 gets better too, right? We all need resources, and we're all sort of at the bottom of the barrel. So, and the other is that it really requires us to get resources out of proportion to the other people that are at the bottom as well. You're not just out of proportion to the people at the top, but out of proportion to the other folks that are at the bottom. And then I worry about the fact that after many, many years of holding the same campaign, that we're sort of vulnerable to somebody that doesn't understand the rankings the way that you've explained them, somebody saying, hey, we've been funding you and supporting you for all these years, and look at all the programs we've been doing, and you guys are still at the bottom of the barrel, And so just thinking this through, but it surely has been an effective way for us to get attention. And we're, incredibly grateful for the work that you guys do putting this together. So thank you.
That is the real, I just want to underscore, we are in a self-reflective phase of whether the benefits have outweighed, whether the benefits continue to outweigh the harms. I'll just be real clear. And so stay tuned for where we land on that. And thank you for the recognition that there are both benefits and harms.
Thank you. Ken, you had a question? Have your hand up?
Yes. Thank you very much, Charmaine. Thank you, everyone. It is a really provocative presentation. And maybe as a segue from what Neil was saying, I just wonder a question about messaging. As you said at the beginning, rankings don't capture or are weak in capturing absolute gains. And not 62, although there's a lot of history behind that, and I think that resonates publicly, I suspect that may sell us short. And if we have absolute gains in these rankings, but other places have absolute gains, we're still at the bottom.
Right.
And the fact that there's progress made is not captured. And people publicly, I've heard, are frustrated by that. So I just wonder, the converse of not 62 is it fails to capture the progress that we're being made. So I'm just wondering, how is that a fair assessment? And how might the messaging be tweaked about that to capture the progress that is made?
Yeah, I think when I hear not 62, I hear a rejection of the blanket categorization of the Bronx as a place that is not working toward health and for everyone. But
Right.
that's because of probably how I see the world. So I would imagine that if you, and I'm not a communications and messaging person, I think the key though is following up the not 62 with both some messages about progress and some messages about why 62 is 62 anyway. So that's where I think there's the most lack of understanding, is why things are the way they are. And I don't know how much you all have worked on building that level of understanding of the why. And so the messaging research from RWJF, I think, might be a tool that would be useful for you in expanding on the not 62 to get underneath it a little bit.
Great. I think it's Sandra, then Teresa, then Red. Sandra?
Yes, I just want to explore a little bit about the idea of the movement and rankings. A few years back, one of the counties near us, Brooklyn, moved up quite substantially in one ranking. How can we go back and look to see what factors contributed to that movement and how that movement happened so quickly? What are some of the strategies? How can we go back and see what actually helped move them like that?
So there is a compare counties feature in the rankings application that you can compare yourself to other counties and then look at the underlying data to see where Brooklyn might have had some substantial improvements in those health outcome areas that shifted their rank. I will also say we hear from people out in practice that, and I don't know a whole bunch about Brooklyn, but what I think I know is that there are some major demographic changes in Brooklyn around income and wealth. And because we know income and wealth are strongly correlated with health, that those demographic changes may have a lot to do with the health outcome of the people living in Brooklyn. And we don't measure those demographic changes in specific relationship to being able to say that that is the driver of a change in a rank. Eunice or Kate, anything you would add there?
I think you covered it, Sherry. I'll just add, I would just like to invite you to take a look at the New York State data. I actually put it in the chat earlier under Teresa's question. But the rankings calculation includes multiple measures and weighting. So it's sometimes, rankings sometimes change more than one would expect, which is kind of counterintuitive to how it really doesn't change, if that makes sense.
Yeah. Thank you, Nick. Terry, I wondered, given what you just said, that a significant demographic change could possibly have such an impact on the rankings, that would you all consider adding that or make a note of it when you put out your report?
Yeah, I mean, it's something that I think we already are aware of, and even the scientific advisory group that we have to help us shape what we do calls out every year. And so I will definitely take it back to the data and analytics team leader to see if we can put that in a frequently FAQ. So we have FAQs about why do ranks change? And I think we could think about adding that as well.
Right, because to Eunice's point, right, that demographic change can change the ranking, but the people who were there, who made originally there, right, their health outcomes may not necessarily have changed.
Exactly.
Just that it got sufficiently by a new, healthier, more affluent population group. And so it's almost a false reading. It's a real reading, but in a sense, it's a false reading. And it may then take away the argument that resources need to be placed there because you're just looking at this ranking and not looking, as you said, Sherry, under the hood as to what may have caused it. And it's not that those people's health improved that dramatically.
Exactly. Yeah. And we hear that a lot from other counties that are experiencing gentrification or other counties that have had long-standing within county differences because of segregation, where one part of the county is doing, you know, gangbusters on income and wealth, and another part of the county has been left behind.
Exactly. So I don't see any hands up anymore. I thought I had seen Red and Teresa. So if you're, oh, Red. Okay.
Yeah, hi. Thank you. This is great. I just have a question about, have you developed any type of curriculum and how to teach these concepts? I think, you know, the discussion about aggregate versus individual data has some really important implications in terms of training the next generation of health professionals of how do we really use this public health information in our day-to-day jobs. Yeah. And I'm just curious if you've, I mean, there's obviously a wealth of information on the website. You know, our organization is involved in educating a number of different health professionals, and it would be great to figure out if there's a way of accessing this in terms of a curriculum.
Yeah, what I would say is we get a lot of requests to use the model in textbooks and get requests for schools to use the data platform for coursework, but we ourselves don't have a curriculum. We have added some videos of how to navigate your snapshot, but this type of conversation where we're getting at the nuances and the cautions and caveats, etc., we don't have a standardized set of resources to walk people through. So we used to have a whole team of what we called coaches, like 15 people that would do presentations around the country that could offer this type of conversation, but we don't have funding for that anymore. So I'm going to take that back to the foundation as well in terms of their role as a funder to see if they have thoughts or ideas about how we could work toward that.
Thank you. You know, again, I'm not really talking about a classroom setting. I'm talking about really kind of the clinical setting of, you know, how to sort of, again, where we have these new tools around population health in a clinical setting. How do we really use that in our training programs? Thanks.
Yeah, so like my colleague and I just wrote a chapter for a book on a textbook on healthcare, and we wrote the chapter on using population health measures like county health rankings and incorporating population health into healthcare. But we don't have a set of tools that are easily translated into clinical training or even to, you know, to classroom public health training.
Thank you.
Nancy, I see your hand. I'm going to let you speak if it's very, very brief, because I'm watching our time.
I understand. And, thank you so much. Incredibly informative, excellent presentation. I think there's a subset of us here who work on the Not 62 committee, and we do a walkthrough of your data every single year. We compare to the prior year, and about 18 months ago, we did a 5-year retrospective to really look at what's changed. And one of the things that I use that data frequently to really like sort of carve out our priorities for the Borough President's Office. And we noticed that occasionally there are things that vanish, like, you know, our big interest at the moment is diabetes surveillance. And we understand, especially at the city level, that because of the pandemic, the money for that just evaporated. It went towards emergency management, all related to the, you know, pandemic. And so my question is, I guess you answered it by saying that some of your coaches vanished due to funding constraints. I wonder whether that also applies to some of the metrics that you use, or some of the things that used to show up as, you know, concrete measures or factors, that being one example. Is that what we're assuming, correct?
Actually, no. So we retire measures more for both because we found a different or a better measure, or because the source of the measure is no longer available. Because remember, we use primarily public available free data, so we don't pay for most of the data. So those two factors are, I think, the two drivers for why something might disappear. Overall, like I said, we're trying to shift upstream. So you should over time see a shift from individual behaviors to community conditions. So measures like school segregation or school funding adequacy, or childcare provider or childcare cost burden. So we're trying to evolve to help the field evolve. And so some of the measures that we might have had, we've retired because we think there's a better measure that is further upstream. Eunice and Kate, what would you add? Because they're on the data and analytics team that are the real experts.
I think you got it, Sherry.
Yeah, I agree.
And all of that is documented in the technical notes. So you can, and I don't know if you guys can put the link to the, why, you know, which measures have been retired.
I want to thank Dr. Sherry Johnson and her colleague Eunice Park and Katie Barnes for this presentation. You gave us much food for thought, and you can see from the questions that were posted in the chat, as well as the questions that were posted here, there is much for us to chew on and try and figure out, particularly for us in the Bronx, how we try and move this forward, right? our Not 62, the campaign for a healthy Bronx. So we do have that other part to it. We just short term we say Not 62. As we are moving along in this meeting, next on our agenda are some ways that we have challenged ourselves in trying to respond to the fact that we are in this place in the ranking. And so I'm gonna call upon next Lauren Sheeman from our health department. Lauren is the Senior Director of Research, Evaluation, and Planning, to talk a little bit about data that the health department uses and also efforts that the health department has in place and put in place as it also works to address our poor health outcomes. Lauren?
So much, Charmaine. Hi, everyone. I think most of you know me, but for those who don't, I'm Lauren Scheinman. I'm the Senior Director of Research in the Bronx office at the Health Department. Very happy to be here today. Is someone sharing my slides, Charmaine, or should I put them up? Oh, perfect. Okay, great. Thank you. So the Health Department has a vast amount of data, as most of you know. I am going to focus today on a couple of things, and I'll try to move quickly so that there's time for questions at the end. I know we're running a little bit behind, but I want to focus today on some of the things that aren't addressed in the county health rankings. You know, as was shared, there's just decisions that have to be made that go into rankings like that. And I think I'm hearing a lot of questions around chronic disease, which is what I really want to focus on today. I heard Dr. Keck mention diabetes, which is a big concern of ours at the health department as well. So I have a lot to share around that. And also sharing more local, more granular data. The health department has community district level data for many, many of the indicators that we track. And so I'm going to share a little bit about how things look across the Bronx, not just Bronx wide. And lastly, I just wanted to say before I start, we're talking a lot today about what makes the Bronx 62nd. I think that's a really important conversation. I do want to acknowledge that the Bronx has a lot of assets, committed coalitions, a lot of green space, a thriving faith-based community. We're not focusing on those things today, but I think those are all factors that are contributing to what does drive change in the Bronx. And whether that moves us out of 62nd or not, we do see improvements in a lot of areas. Great, so next slide, please. So I'm going to talk first about premature mortality. At the health department, we consider premature mortality to be deaths before age 65. Next slide. So the leading drivers of premature mortality in the Bronx, premature deaths, are due to chronic disease. Number one is cancer, number two is heart disease, and then after that we see drug-related deaths. This differs from the city overall, so I want to highlight that one. And diabetes is up there as number 4, so really, really important. And HIV, number 5. I think that always surprises me with all the treatments that we have available, so it really speaks to that piece about how we allocate resources. Next slide. So just talking a little bit more specifically about diabetes. Next slide. The Bronx has the highest percentage of people living with diabetes in New York City. So you can see 15.8% of people, adults in the Bronx, have ever been told by a health professional that they have diabetes. And when you compare that to Manhattan, 9.4%, we see we really have a lot of work to do. Next slide. This slide is showing the percentage of people who were told they have diabetes by a health professional by community district. So you can see the Bronx average, as I said, is 15.8. There are 5 community districts in the Bronx that are higher than that, but almost all of the community districts in the Bronx are higher than the New York City average. Just Riverdale and Fieldston is below the New York City average. So I think when we talk about what makes us 62nd and what makes us the least healthy county, we think of it in aggregate, right? We think of the Bronx overall. But someone mentioned earlier, Brooklyn is changing rapidly, right? There are neighborhoods in Brooklyn that do as poorly with respect to many of these health indicators as parts of the Bronx. The difference is that there are many neighborhoods in the Bronx, almost, I would say, most neighborhoods in the Bronx that are suffering from lack of resources, disinvestment, structural racism, segregation, air pollution, all of the things that we talk about. And that's not the case in Brooklyn, right? So that's, I think, where we see this difference. And what I really want to focus on is that we have this granular data, we can look at where to focus. And sometimes when we look at the Bronx, it's hard to know where to focus because so many of our community districts and zip codes have such high need. Next slide. This is showing uncontrolled diabetes. So when we think about diabetes, once you've been told you have diabetes, you're going to be counted in that percentage, right, that I showed on the prior slide. But we can also think about people who are controlling their blood sugar level versus those who aren't. And in the Bronx, we see the highest percentage of folks who have diabetes who are living with high blood sugar levels. And here we define that as A1C above 9%. Next slide. And then again, just looking at this at a neighborhood level, we see that only the Riverdale area, again, is lower than the New York City average with respect to uncontrolled diabetes. Next slide. So I have a couple slides here about risk factors for chronic disease. So obesity, next slide. You can see again, it's repetitive, right? So all of the community districts in the Bronx have a higher percentage of adults who have a body mass index of 30 or greater, which we consider to be people living with obesity, except for Riverdale and Fieldston. All of them are higher than the New York City average. Next slide. Physical activity, of course, is another big predictor of chronic disease and a way to mitigate risks of chronic disease. And here we actually see, this is really interesting to me, we see improvement, right? So only only 4 community districts in the Bronx have reported more than 30 days, have reported doing any physical activity in the 30 days prior to a survey. So report being physically active to any extent. So yes, it's not great. We still see most of the Bronx is doing worse than the citywide average. And remember here, a lower percentage would be considered less healthy behavior. But we see at least a couple of neighborhoods that are higher than New York City average here. Next slide. And then lastly, I want to touch on sugary drink consumption. I know this group has done a lot of work on this in the past. Next slide. And here we see all the community districts in the Bronx have a higher consumption of sugary drinks than the New York City average. And you can see those on the top are the ones that have the highest percentage of adults who consume at least 1 sugary drink per day. Next slide. Oh, sorry, I thought that was my last one. Quickly, I'll go through fruits and vegetable consumption. So again, just showing this in the same format. So we see that almost 90% among New York City adults have at least 1 serving of fruits or vegetables in the day prior to taking the survey. So we consider that daily consumption of fruits and vegetables. And we see those that have the lowest consumption here, Kingsbridge Heights and Bedford, Highbridge and Concourse, Morrisania and Crotona, can tell us a little bit about where to focus. And also in thinking about that limited food availability indicator that we saw earlier, we know that access to healthy food is not just being within a mile of a grocery store, but I think this indicator helps me to see, like, we're not meeting the need. It's not affordable, it's not high quality, people aren't able to obtain it or aren't choosing to eat it. Next slide. So I wanted to share a couple of additional resources before we wrap up. I heard a lot
I'm in a meeting.
I heard a lot of calls for more granular data. I think folks know the health department has more data than we know what to do with, and we're always happy to share. But these are a couple sources you can access on your own. So I put the links right in here, and it's fine if the slides are shared out after this meeting. But one is EpiQuery. It's a website that you can go to and access health department data in real time. And there's a picture of it on the bottom left. You can click on different topic areas to explore different health conditions, mental health, healthy living, physical environment. I also wanted to share the environmental health portal. That's the second link and the middle picture. This gives a snapshot of some disease-related indicators, but also more environmental and community conditions. And you can look at both of these by neighborhood. And then lastly, I think probably everyone here is familiar with the community health profiles. Many of you have been emailing me relentlessly that the profiles have not been updated. I am here today to share really exciting news. We have soft launched the new community health profiles on our website. The link is right there, that third link. And we are really, really excited about this. I do want to flag, our team has asked me to report that they are struggling with a couple technical difficulties. That's why there hasn't been a public announcement yet. When you click on particular maps, you may get like an error message about that map. Just ignore it. The map is working fine. They can't get rid of the error message. And this is out of my area of technical expertise, but they're working on it, and there will be a broader launch soon. But the important thing is that the data is available. So people are able to go on and see more updated data at a community district level. Yes, I'll add the links in the chat in one moment. No problem. And I also wanted to say, if you go to the next slide, it's just my contact information. The Bronx office at the health department is here. We answer any data requests that are needed. We can also help groups to interpret data, think about how to use this data in their work. So please don't hesitate to reach out to me. I shared today only a very, very small snapshot of all of the data available to us. So if there's a particular thing that would help in program planning, in a grant application, please don't hesitate to reach out. My team's available to respond to data requests, to give presentations to your staff, or to help support with technical assistance any way we can. Thanks. I'm happy to take any questions, and I'll add those links to the chat.
Thank you, Lauren. I'm going to ask folks, if you have questions, to jot them down, because what I'd like to do is have the other folks who are also going to speak, and then we can respond to questions you had from any of these presentations, starting with Lauren's own. So our next person is Dr. Nancy Keck, who's the Director of Health and Human Services from the Bar President's Office. And she's going to speak about what the Bar President is planning to do, her plans, either ones that she's putting in place now, ones that she has to come. Yeah, we're really glad to have you here with us, Nancy. Go ahead, Nancy. And Nancy, your hand.
Oh, my hand is still up. My apologies.
Yeah.
Thank you, everyone. It's great to see faces of many, many, many partners here today. And part of, I was going to say, going on after Dr. Johnson and Lauren is like, you know, performing after Beyonce. So I am shifting gears now, even though we love and really utilize the data that both entities provide, Robert Woods Johnson and the Department of Health in the Bronx. We're very grateful. We use everything you produce to really apply an evidence-based lens to the work of the Bar President's Office. And I have a lot of info here. I'm not going through it. I want to respect everyone's time, and also my wonderful colleague, Liz Farrell, who goes after me. All the work that we do is really effectuated, both, you know, internal and external, through a series of borough-wide bodies. And I've outlined what some of them are. This week is the 1-year anniversary of me having a new staff. I know at least one of my community health and public health liaisons are on, Mahnur Jara and Shruti Khanna. We have really taken the basic agenda and moved forward in lightning speed with some of our main pillars, real high priority health agendas. And so I'm going to tell you just a little bit about the ones where we've made the most progress. In addition, the QR code that's at the top of that, and I'm sure some of you are interested in that, it's also available on the Bar President's website. That is to the strategic policy statement that we worked on last year and published when she did her first State of the Borough. And it really outlines the areas across all of the Bar President's agendas and every division in the office. What are the things that we've identified that we really want to work on, need to work on, and have already invested in? So if you look, the health committees that are already in existence that we really moved forward on include, you know, the Not 62 campaign, a brand new entity called the Bronx Maternal Health Consortium, which members here, some of them serve on. That evolved from a task force that we use to align experts across the borough. I'll briefly tell you about where we're going with that. We also have a DV advisory council that is borough-wide, that is huge. My document shows you who some of the organizations are. It's really a way of tying together, in each case, every single entity, major, small, and big, public and private agencies and CBOs and faith-based organizations to really network individuals that are working on common goals and around these large social and health problems. We have a legacy HIV roundtable that really was defunct for a year or two, particularly since there was a lot of change of staff in our office with the transition. And my colleague, Shruti Khanna, has really resurrected that body and breathed tremendous life in it. We now meet borough, city, and state entities meet collectively in quarterly meetings, and we've had health policy trainings to really move things ahead. And then we have received a Department of Justice grant that looks at specifically a strangulation initiative, since that is indicative of future intimate partner homicide. And there's a fabulous model that we're working on with 4 other entities, which includes the Bronx DA's office, Safe Horizon, NILAG, New York Legal Assistance Group, and the Department of Probation. We just did a huge community needs assessment with all the people on that new advisory committee in its current iteration, and have really discovered what unmet needs there are and refined what our role can really be in serving as a borough-wide convener of all of these stakeholders. I have also, in addition to the work and joining a trafficking task force, which is a huge problem in the Bronx, I have to say, hidden, but out in it, openly there, but yet hidden because people do not talk about this. And also a mayor's task force on female genital mutilation and cutting. And all of these really represent crimes against women and children. And we, in the borough president's office, have a unique lens to issues that may not have really come to light before we had an all-female administration and a female health director. So we're really looking at unmet needs and things that need to happen in the borough at a social, emotional, political level that may not have had attention before. We also, I want to say, learn a tremendous amount from Bronx Health REACH. We join periodically, although not often enough, 2 of the important working groups, one on fitness and nutrition and the other one on health disparities. And it is a way in which we sometimes can contribute and other times learn about, at a very granular community level, through the lens of Bronx Health REACH, how Bronxites live, eat, suffer, thrive, and persist in this sort of post-pandemic world. So it is a way for us to connect with all of you and to understand better and to recalibrate our health work in the borough president's office to align with and support what you're doing. So we have some new things we want to do in 2023. We are very focused on diabetes. It is a huge problem in the borough. And Lauren's data was, insightful. I think there are many more people who have diabetes or are pre-diabetic who don't even know it and therefore are not even counted in those numbers. And some of the data, we asked the Bronx Health Department to use EpiQuery to give us, to do an environmental scan on diabetes in the borough. And some of the numbers are really terrible. In some zip codes, there are people, 1 in 4 people have diagnosed diabetes. If you consider those who are as of yet discovered, it's even higher, and that is tragic. So that is a major focus for us. In addition, we need some more expertise in the office, some more bodies and minds to help us work on opioids as well. We are actively planning a directory of agencies and providers that work in this space, so that it's a very huge industry and a huge problem. And there's very little guidance in finding information, both for families, for us as local government, and even for providers. There's no link, and a lot of entities work in silos. So we are looking at that to really do a community assessment around that. We rely heavily on Montefiore and our hospital partners to look at their community needs assessments and work closely with them in order to understand where some of the areas where we can have influence and provide support and raise priority. In the end, there's a couple of things that we're developing that I will not mention, but the last one is since Dr. Johnson mentioned air quality and the Cross Bronx Expressway, New York State has an ongoing air quality monitoring project, and we have been tasked as co-conveners to actually create a community advisory group. I believe it should be incredibly diverse and reflect, activists, health advocates, education, business sector, to really look at the data that is going to come out from those air quality measures. They look at particulate pollution as well as greenhouse gases, and they map them at a very detailed level with these very interesting souped up Prius vehicles. It's a public-private partnership. And in the end, we have to decide at a community level, what do we want to do with that data when we get it? We're almost by the year end, we will have a year's worth of data and maps that are going to show where is this horrible pollution. And there are policy things that have to be determined. I think the data will reveal by the nature of what the pollution is, who the polluters are, and there have to be ways of dealing with that. So I urge everyone on this call, and we will be calling out to larger groups, but very targeted ones, including the Cross Bronx Expressway Coalition, to volunteer, to represent, and to be present in those data discussions. And when it is rolled out slowly, so that when the maps are complete, we have a voice in how that information is going to be used. And so that's another push that we are actively working on right now. I'm going to stop there because I want to say we have 2 reports that are coming out, one of which is really derives from the community of the Bronx Maternal Health Consortium and our office and Bronx Health Link. We are pushing hard for implementing some of the recommendations of the Black Maternal Mortality Task Force of 2 years ago. Systematically, we've been working on those. And one of the things we want to discuss is a birthing center in the Bronx. And so that we have a large paper that is going to be reviewed this month by our consortium, and it will be released. And we also have an environmental health justice report on raw sewage coming from Mount Vernon down the Hutchinson River, where we know Bronxites come and swim, play, fish, and eat their catch. And so it's very important. These 2 projects are absolutely pivotal, and our public reports are meant to really start a public dialogue around those. So that's it. Thank you. I apologize for the brevity and running through it quickly. I respect all of you. Anyone who has questions, please reach out to us. Take a look at our strategic plan. I am open to anyone for comments, questions, and it doesn't have to be now. It could be offline so that we can give Liz and others a chance to also contribute to today.
Thank you, Nancy. We are particularly, we're especially happy that Vanessa Gibson is the bar president leading the charge. She had not been shy, even before she became bar president, about championing the fact that something has to be done with our 62 standing. And we are looking forward to a lot of really important things happening during this first term of her administration to really move us ahead. Next, we're going to have Liz Burrell Huss. I'm glad we added the Huss part to Liz's name. Liz, who sits on the Not 62 Steering Committee, is from Monty. That is one of the founding partners of this initiative. Liz is going to speak about some of the work that the some of the work that the Not 62 Steering Committee has been involved in. Liz?
Thank you so much, Charmaine, and thanks to the group for inviting me. It's been a pleasure being part of the Not 62 steering committee for the past 5 years, but just want to acknowledge Charmaine and my colleague at Montefiore, Melissa Caballero, and Anita Reyes and Fernando Torrado, and there's others too have been involved since the campaign launched over close to 10 years ago, maybe 10 years ago now. And just really proud that Montefiore is a founding member and continues to be so involved. We underwent a sort of strategic planning process that started in late 2021 and kind of finished up early last year. And thank you to Anita and her colleagues at the health department for helping us to get a consulting group that really sat down with us so we could share with them all that had been going on for the previous 8 years, but also our vision for the future. And we're able to help us sort of record that. So not only do we have a beautiful timeline of all the progress to date and what sort of all the activities and things that had happened, but we also could sort of look to the future in a more structured and intentional way so that we could be even more effective. And I'm sure we're happy to kind of share some of these materials with the group so you can kind of see the breadth and depth of the work. But just to point out a couple of things, like one, we were able to really articulate that up until that point, the function or the role of the coalition really had been to build awareness about health in the Bronx and health inequities, as well as to help develop partnerships and sort of lift up the initiatives that have been going on in the Bronx thus far. So we were able to kind of say, yes, this is what we've been doing, and this is part of what we also will hope to continue to do moving forward and for the next 5 years and beyond. We were able to sort of think about the development both of how we can improve our internal infrastructure, or enhance, I should say, our internal infrastructure. And I'll talk about that in a second, but also what an enhanced public engagement looked like for the coalition. So in terms of the internal infrastructure, and I think Charmaine mentioned this earlier, it's been really important for us, and we had been talking about this for some time, of sort of doing more or engaging more sectors other than like health and public health in the coalition to sort of help folks to understand what their role is in health, even if they're not identified as a health or public health person. And so with this strategic plan, we were able to really identify specific organizations that we wanted to reach out to invite to be part of the steering committee, so we can sort of expand that leadership to not just be health, although there are some other health folks on there, but we also have representation from higher education, right? We have Dr. Willis, who I know has spoken here from Lehman College now on the team. We have Steve Ritz from the Bronx Green Machine. We have folks from the faith-based sector. We have housing representation. And so we have been really able to expand so that as health people, like that's our lens. But it's really important that we sort of have more voice and different perspectives, because we know, as we've heard from Dr. Johnson, and we all know because we're here today, like that health isn't everything. And so as a coalition, we really need to reflect that. And then part of that expansion was also the development of specific subcommittees that relate to 5 areas of action that the coalition has decided that we want to move forward with, and I'll talk about that in a second. So that's the internal infrastructure piece. There's also this public engagement piece, as I mentioned, which was us identifying priorities, checking in with our steering committee members about those priorities, and then sort of developing action plans from those priorities, and then continuing to amplify partner initiatives. So it's not necessarily that the coalition wants to like develop new programming or sort of start something new, although maybe we would do that together, but it's really about bringing together and aligning efforts so that we can have the most impact over time. In terms of our specific strategies and tactics that we developed as a group as part of this strategic planning moving forward, they kind of fell into 2 buckets. One was shifting paradigms, and the other is making connections. And I don't know, Charmaine, I have a couple of slides. I don't know if it helps to kind of illuminate this if I share my screen. Would that be okay? Okay.
Sure. Go ahead. Liz.
Okay. Just because I know I'm saying a lot of words, and I think I'm a visual person, so maybe I thought it might help. Can I share? I can. Cool. So can you see my screen here?
Yes, Liz.
Try to make it a little bit bigger. Okay. So these are the strategies, as I mentioned. I'll go back into this in a second, but just as a recognition that the Not 62 approach is holistic and cross-sectional. You know, we added, I think we've always been moving to advanced health equity, but we were very explicit about that in this strategic planning process, that health equity is not just about healthcare and access and public health policy, it's fundamentally about improving quality of life, the health and wellness of Bronx residents. And so we have to consider all aspects of life and address inequities in all these different sectors. So getting into these two strategies in a little bit more detail, the shifting paradigm strategy, I think, is something the campaign has been doing all along, but again, something that we really want to commit to even more. So it's clearly communicating that the Bronx is the least healthy county in New York State, but also looking to change the conversation around health in the Bronx, calling on elected officials and other leaders to prioritize health for the borough. It kind of goes along with I think what Dr. Johnson was recommending, which is what we have been trying to do, which is recognizing that this is where we are and why we're here, but also amplifying some of the positive changes that have happened and building on that over time, and acknowledging that everyone has a role to play in making the Bronx healthier, that we can help people kind of plug into what their role could be. And then along this sort of making connections strategy, you know, helping to facilitate connections and collaborate with multi-sector partners. We want to continue to be an information conduit between partners across sectors, and I think do that in a more intentional and meaningful way. And then if we could be a key catalyst of actions taken by partners. So not just sharing information, but sort of doing some planning together so that we can, again, you know, kind of join forces, and whether that's applying for funding together or promoting certain policies with our elected officials and coming together as a collective to do that. I think it's all about, at least from my perspective, sort of that intentionality in not just amplifying, but also moving things forward together. In terms of the specific action areas, you can see the 5 listed here. And the first 3 are really what we're going to prioritize in the first few years. So the first 3 years. Not that the other 2 aren't important, but it's a lot to tackle at one time. And so the thinking is that we are in this process, sort of developing subcommittees for each of these action areas. And we have extended the offer to co-chair to our new steering committee members, but also welcome members from the community, you know, and representatives of CBOs in the community to be part of these subcommittees as well. And the idea will be, of course, that we'll sort of develop goals and strategies about how we can move forward in these areas over the next few years, and have specific metrics tied to these different action areas to know that we're actually affecting change. But so that's all that I have. I think I could just say where we are is that we as I said, we had this new steering committee. We are sort of meeting over the next month as individual subcommittee co-chairs, and then looking to expand the subcommittee in the fall so that those subcommittees can kind of start their individual work. Nancy, Charmaine, Anita, anything I missed that would be important to add?
Nancy, you had your hand up. You wanted to say something?
Yes. So one of the things, thank you so much for encapsulating some of the work that happened over many months, 6-7 months in a room where we were all chained together in order to do strategic planning. One of the things that came out of our, that I failed to mention earlier because I was rushing through, is that the policy work is really one of the most important and enduring ways in which we can actually create change by developing supportive and protective laws that have impact and duration far beyond health fairs and outreach and a lot of the other activities that we engage with, you know, at the community level. And that's an example that for example, for the maternal health work that we have been doing, we realized that in 1 year, we were able to pass 11 laws to really work on the front end, on behind the scenes, to go provide testimony, to raise awareness and priority. So one of the things that came out in our strategic planning was that Not 62 really would like to do workshops to improve the health literacy of our Bronx elected officials. And that we think that that is an important way in which to galvanize and focus their attention on the things that we need the most at the community level, and to really help create the ideas for, the policy work that we think needs to be done at our level, and embrace the local officials who have the capacity then to actually draft those bills at the city and state level and work on that as being part of our overall strategic plan. So we're very eager and very purposeful, I think, in advancing that. And I wanted to just put that in there because that's an important thing between Charmaine, Melissa Ceballero, Liz, and the larger coalition that did this planning. We have not really talked about that or articulated it, but at the mere mention of that to the borough president, she was like ready to do something with it. So that's it. I wanted to really put that out there that for us in our office, it's a high priority. Next.
Thank you, Nick. Thank you. And so next we're going to have the Reverend Dr. Wendy Kelly Carter speak about the recent work the Bronx Health REACH Health Disparity Work Group has undertaken. For Bronx Health REACH, the Health Disparity Work Group is where we have put the Not 62 work. Bronx Health REACH's participation in the Not 62 campaign is housed in the Health Disparity Work Group. And the Reverend Dr. Wendy Kelly Carter is going to update folks about what that work group has been doing.
Thank you, Charmaine, and to others. Good afternoon. The Health Disparities Work Group is currently working with Fordham faculty to get their input on our asks for elected officials. These asks center on health, housing, and economic development. On April 27, 2023, the work group had its first roundtable with Fordham faculty, including Dr. Shelley Versey, Dr. Janice Barry, and Dr. Robert Brent. This roundtable was used to gather insight from these professors on our economic ask. The subcommittee is currently in the process of setting up the next roundtables to discuss the health and housing ask. This partnership with Fordham has informed some unique opportunities for youth involvement in the Health Disparities Work Group. Fordham has community engaged learning courses every semester, where the professors guide the students in projects for community improvement. Where these projects align with our ask, students will be able to join the Health Disparities Work Group or specific partners in this semester-long project. The Health Disparities Work Group is also planning to engage in a grassroots campaign centered around the ask and Not 62. The Health Disparity Work Group met with Borough President Vanessa Gibson on March 30th, and what a time we had. And we were able to share and discuss the acts with her and to hear from her the plan she has to address the Bronx 62 status. And so that is some of the accomplishments we have done thus far, and others, but those are the highlights. Thank you.
Thank you, Reverend Wendy. The one thing I would add, as Liz was doing her presentation, it jogged my memory that we've added a mental health piece to our health ask. That is something that has been driven home very forcefully to Bronx Health REACH since the pandemic. Several members, clergy members, as well as community-based leaders have pointed out to us what they've observed, both in terms of the people that they serve and even amongst their leadership, clergy members, that mental health and those concerns have sort of risen to the forefront. And so with that in mind, and with the urging of Brett Scudder, who is a part of the Health Disparity Work Group, we added mental health to our health app. So I just wanted to add that piece to what Reverend Wendy just presented. For the Health Disparity Work Group members that are present here, was there anything else you think we should say for the talk about the Health Disparity Work Group for this meeting? No? Okay, so we have given you a lot of information. We thought it was important, as much as we hate the fact that we're not 62, it is the reality, and we have to grapple with it. We thought it would be really helpful, and I think you all would agree that having Dr. Sherry Johnson and her colleagues from the University of Wisconsin coming and sort of breaking down for us that rankings report and allowing us to ask questions about, the source of that data, how do they do the ranking? Dr. Kalman asked a question that was forefront in my mind when he asked, is there any possibility of the Bronx improving its status? I had the question, is there any county across the country when they've been doing these rankings across these, I think, 15 years, has any county shown a dramatic improvement, and why? And I wish we had had the time to ask them those questions. The other thing that jumped out at me was when Sherry mentioned that they've added the 2 new measures, census participation and voter turnout. There is, and I've mentioned this at I think a coalition meeting 2 years ago, either last year or the year before, that Daniel Dawes has written this book, Political Determinants of Health. And it struck me that these 2 measures are actually a part of that there is a clear connection between political activity, who shows up, who turns up as voters, who then get elected, the elected officials' accountability to their community. So that was important to hear from our University of Wisconsin presenters about those 2 new things. And it was also great to hear from the health department about the chronic disease measures that they're looking at, and then to have Nancy talk about the bar president, because what the health department presented and then what Nancy talked about the bar president doing, seemed you could draw a line between those 2 that is very much informing the bar president's health agenda. And then it was, I hope you all benefited from hearing Liz talk about the work of the steering committee, the plans that have been put in place after we worked with a consultant for about 18 months on developing the new blueprint for the next 5 years. When we started the steering committee, the goal was to develop sort of a multi-sectoral coalition, and then building, and then the work with the consultant for the to build on that is a blueprint for the next 5 years, and maybe and hearing Liz sort of lay out the 5 main features would be great. Maybe another time we can have more of the steering committee members come on and talk about, particularly the new ones, and talk about why this was so important for them to ask to join this, and what are their plans in order to move this ahead. And then finally, for you to hear from Bronx Health REACH's Health Disparity Work Group about the work that we're doing. That Health Disparity Work Group is really a grassroots effort to draw as much attention as possible on attention of the community on the fact that the Bronx is ranked 62 out of 62, and to develop a movement from the grassroots to amplify this and to ask our policymakers, our elected officials, those who are in positions of influence, about making the necessary changes if we are to come out of being 62. But Lauren's point, and I think part of Sherry Johnson's point, is that while we are 62 and while there are lots of factors at work, it's also important for us to highlight that there have been improvements in it, that there have been changes, that the people who have been working have not been working in vain. Yes, we have a lot of work to do, but there are encouraging signs along the way about the impact that this focus has been having, and the impact of the many folks working in the Bronx to improve the health of the Bronx have been having. So I wanted to highlight that really important point. Finally, are there any announcements that people want to make? Thank you, Teresa. Are there any announcements people want to make before we close off? We were hoping, one announcement from me. We were hoping to preview a communications campaign that Bronx Health REACH is going to has launched around encouraging people to have their COVID shots and their COVID booster shots. I don't know how many of you saw, but there was something recently that through our health folks looking at our wastewater, there is being seen an uptick in COVID cases. So yes, the federal government may have stepped down COVID from being an emergency. COVID, however, has not disappeared. And it's really important that people who have not received their COVID vaccines get it. And it's important that people who have received their COVID vaccine but need to get their boosters, get their boosters. So we launched a campaign particularly focused at pregnant women and parents of young children. And we've been having it on our, we've been having it on Link NYC and some subways, and now we're going to put in place the digital version. We were hoping to preview it here, but unfortunately, Michael Johnson, our communications associate, is not feeling well and so was not able to do it this morning. So, Alma. Sorry, Alma, I didn't see your hand. Go ahead, Alma. Yes,
Hi.
Teresa, Michael sent the link out. Alma?
Yes, hello everyone, and great meeting. Sorry I got on late for some reason. I thought it was in person and I didn't see that till late, but I'm happy to be here. So excuse me if I missed this piece covering in the presentation, and I'm going to pull Teresa in with me on this. Health disparities as it relates to breastfeeding and infant outcomes is certainly a huge piece. It goes to nutrition as well, which I know the coalition really focuses on in an aspect of their work. The Bronx, every data set that I've looked at and I've asked partners to share have had difficulties or challenges showing what the numbers are for the Bronx. Does the Bronx breastfeed? So we're not even just talking about African-American population, which we know data says sometimes that African-Americans are the lowest numbers of folks that are breastfeeding. And we've seen information to the contrary. But more importantly, finding data about the Bronx in terms of breastfeeding initiation, that's reasonable because fortunately we are mostly baby-friendly hospitals in the Bronx. So breastfeeding initiation is certainly a part of what happens in the hospital. Post-discharge, on the other hand, and beyond the 5-day measure that's collected, we really don't know how many, what percentage of Bronx population for new mothers, new babies, new infants, newborns that are breastfed. We also don't know the duration. How long did they breastfeed? We know that the data and the guidance from the Healthy People 2020, CDC, and other systems indicate best practice and for best outcomes for infants, 12-month exclusive. We are concerned about knowing what's happening in the Bronx because we don't. Most of the time, the reports, whether it's MPINC data, whether it's CDC data, whether it's the WIC data, most of the time you see an asterisk as it relates to the Bronx. And the data is quote unquote suppressed because it's too small, or there's some confidence interval concerns about it. So we get sort of lumped in that, oh yeah, the Bronx is at this percent. What we do know, we have a high percentage, about 90% of our babies have had breast milk at birth, but there's a 24% with duration beyond those 5 days, numbers of time in the hospital. I think it is an imperative for us to understand what is going on as it relates to newborn and their nutrition, as well as implications for good health outcomes for both mothers and babies. And so having on the agenda here, breastfeeding support, breastfeeding resources, I believe is critical. We do have a Bronx Breastfeeding Coalition, like a lot of other cities and states, which is a mechanism that is, other states use to be able to support breastfeeding persons. And so there's a meeting, and which is why I said I'll put Teresa on the spot because she co-chairs the Breastfeeding Coalition. But we just had a meeting recently, the Bronx Breastfeeding reconvening, because we've been doing this for 3 years, trying to move the needle, hopefully at least gain information about what we're doing in the borough around breastfeeding. And so I would certainly appeal to this committee, the leadership, the guidance, the steering committees for the Not 62 to add on the matter of infant nutrition, which is breastfeeding, to the agenda and the strategic plan for a surveillance to understand, does the Bronx breastfeed and to what extent? And what are the resources and support that they need, which should also go to Nancy's work as it relates to policy and advocacy for resource and support for new pregnant persons, as well as lactating individuals across our great borough. Thank you. Teresa, I know we do have a coalition meeting coming up, so maybe you want to give that date? Thank you.
She put it in the chat, June 14th, 12 to 2 p.m. Thank you, Teresa. Dr. Celia Dick, your hand is up.
Yes, hi. Thank you so much. This was an excellent session. I really enjoyed participating, but I just had a quick announcement. Yesterday, I attended a meeting that was held by the Department of Transportation, and basically this revolves around the Cross Bronx Expressway. So they're having some issue identification workshops starting in June. The purpose of which is to kind of refine the most urgent issues relating to the Cross Bronx and its impact on the surrounding communities. So I will try to post in the chat the registration link for the event, but we want to publicize it to get community turnout so that the community can attend in order to help shape the narrative moving forward. So let's see if that shows up in the chat. Yes.
There you go. Thank you, Dr. Dick, for reminding us. I'm participating in that group that's doing it. And they had reached out to us, but it's never too much
Mhm.
to be reminded, to have folks be reminded about it, because Bronx Health REACH got it, but there are folks here from several organizations that have direct community contact, and it's good for them to know about it as well.
Yes.
Dr.
Do you have the
Brittany
link?
is capping the Cross Bronx
Yes.
Expressway, right?
Yes. Do you have the link for the event, or should I share it as well as
Share
flyers and all
it.
that?
Yeah, please share it with us.
Okay, thank you.
All right, very good. Thank you. Any other announcements? No?
Hi,
All
Charmaine.
right.
I'm sorry, pardon me, real quick.
Oh,
This is Linda Bonilla, formerly
Mhm.
New York
Go
City
ahead.
Parks, but now at the New York City Civic Engagement Commission. Thank you. This was a wonderful, wonderful session. It's been a while since I've joined, and I want to appreciate everyone who organizes this. It's so insightful, and it really helps to continue and advocating for the narrative for the changes that we want citywide, and especially in our borough for the Bronx. I just put in the chat, right now we are in the voting session for, it's called the People's Money. And it's, in short, it is participatory budgeting that has been implemented. It started 2018 when it was voted into the ballot. But I work at the agency that is implementing this type of expense-based participatory budgeting process, where we are working with neighborhoods, in particular neighborhoods that have been affected that have been historically redlined, that hasn't been affected by COVID, and all the neighborhoods that we all try to work to help create change or make that impact for, as well as the other neighborhoods in our respective boroughs. But there are community projects, services, and events that are on this ballot. And the vote started May 10th, but it is open through June 25th at 11:59 p.m. I pasted the link as well. The requirements is that you just know your zip code. Where you live is where you vote. The exception are for students. Students can vote where they go to school at or where they live. And you could be as old as 11 years old and up to make those votes, to make those decisions. This is to help start building more equity and just rebuilding civic engagement with deliberative democracy process, as well as people who have issues with that. It's regardless of status, and if you're houseless as well. Like everyone, this is an opportunity to really just rethink how we want to rebuild communities with this agency. If you have any questions, Charmaine, I believe I've shared my information with you, but I could do it here in the chat as well, and Anita too. But thank you for the space to allow me to share this opportunity to just share with your clients and your friends and your neighbors. And this is not just for the Bronx, this is citywide. Thank you so much, Charmaine.
Thank you, Linda. Glad to have you. We've missed you. All right. So if there are no other announcements, thank you all for attending and participating in our coalition meeting. We're really glad to see you all. Our next coalition meeting will be in September. So between that and now, have a great summer. Take good care of yourselves.